Is it a longer implant that makes the difference, or is it a wider implant that makes the difference? And I think the majority of studies have shown that the wider implants really contribute much greater to primary stability and higher insertion torque values. And this implant, if I can just explain a little bit, has a tapered portion that is widest about the mid implant level with aggressive cutting threads. And then we have a transition zone leading up to this cylindrical portion of the implant that is a millimeter narrower than the widest portion with less aggressive cutting threads because we're really not engaging much bone at all. And it gives us room for either augmentation or socket shield or other procedures that you would like to perform in between that facial tissue and the facial surface of the implant. And so this contributes to improving this immediate tooth replacement therapy because one, we achieve great bone thickness facially with that narrower top. We increase or improve our implant tooth distance compared to a standard tapered implant, which would be widest at the crest. And we don't run into these apical perforations because the implant is angulated palatally. And this is all because of this subcrestal angle correction. And we know we have to graft from many studies, and Levin showed this quite a long time ago, that if you graft a maxillary anterior site, the likelihood that you will have to perform additional grafting drops significantly compared to these anterior sites that were allowed to heal on their own. Much more three-dimensional bone volume is preserved when a graft is placed. So when we put this implant into an extraction socket, we see that the coronal portion is not touching much by way of the socket walls. And so we may have an insertion torque that makes us feel good, but we know that we're going to lose some of that primary stability as bone models and remodels in the cancellous region around the implant. So how do we know that this implant is ready for restoration or final restoration? How do we gauge that this implant has trended in the right direction? Well, we performed this study, and what we found, which I'll talk about, is the initial insertion torque of this type of implant was almost 52 Newton centimeters. And if you think to that parallel walled study, the average insertion torque value was 28 Newton centimeters. So we're almost double in terms of insertion torque. So if insertion torque is your main parameter to feel good about immediately loading an implant or temporizing an implant, this implant will satisfy virtually everyone. And this is without any under preparation, osteodensification, osteotome use compaction, anything. This was the straight protocol. And the ISQ was 67.8, virtually the same as the parallel wall study. And we had a predictable increase of about 5-6 ISQ values when we went to follow-up. And what this told us was that this coronal portion of the implant was osseointegrated when we referred the patient back after follow-up ISQ values.